Hello, everyone. Welcome back to Youthful Medicine. I am Dr. Tahir, a rheumatologist and a board certified obesity medicine specialist. Today, we are discussing a common challenge for patients who I see for osteoporosis, which is to continuing long term treatment with Reclast or switching to another therapy such as Prolia. Specifically, I'll be talking about a 74 years old female patient who has been on Reclast for about 10 years. Should she continue this drug? Should she switch to Prolia? Should she take a drug holiday? Well, let's explore the potential benefits and risk of each option. As we know that our population of patients that we see, they are on average living longer than the previous generations. And in order to make sure that they stay out of the hospitals and don't break bones, we are, as rheumatologists, treating their bone density much more, um, I should say, we are much more alert about the fact that we need to avoid any unwanted fractures. So let's start with the potential benefits of Reclast uh, overall. Well, if we continue the Reclast medication, we are continue to preserve the bone. Continued fracture protection of Reclast has been documented. Initially, it was recommended for first 5 years of the treatment, and now it has been extended between 5 to 10 years of treatment. Reclast has shown to effectively reduce the fracture risk in patients with osteoporosis. Even after 10 years, it can continue to protect against fractures, especially in patients who have high risk of fracture. Now, those are the people who are older or people who have had previous fracture. Now, you have to know that the patients who receive Reclast have to have normal kidney function, because if the kidney function declines, the frequency of the medication has to be decreased, or the patient has to be switched to another medication. Now, stable bone mineral density for patients who have had a stable bone mineral density or their bone mineral density has increased over the years, continued Reclast can help sustain them and keep them in sustained and keep their bones strong. And there is also another option called infrequent dosing, where patients, if they are have received about Reclast for 10 years and they are at a steady state, an infrequent schedule of Reclast can be given. Reclast is overall a very convenient medicine. It is given once a year infusion, which eliminates the need for more frequent doctor visits, and cost is also it's a very cost effective drug. This convenience make it easier for patients to adhere to their therapy, and in some cases, when the patients have achieved the goal, we even switch the medication from 1 year to every 2 years therapy. Now, let's discuss a little bit about what are the risks of continuing Reclast after 5 years. Well, there are some risks. There are important risks that to consider when long-term use of any medication is used, especially Reclast, after 5 years. Well, the risk of osteonecrosis of the jawbone is common. While rare, osteonecrosis of the jawbone question comes up almost in every visit that I have with my patients. It becomes slightly concerning that the prolonged bisphosphonate use, the category of Reclast, which is called bisphosphonate use, goes up beyond 5 to 10 years mark. If we have been giving the medication for that long, the risk of osteonecrosis is now rising. It is important to monitor for any dental or jaw pain and making sure that our patients are getting regular dental visits. I ask my patients, actually, they should schedule your dental visit a month before you come to see me so that you know if there is any need for any surgery procedure, any infection that might be going on. The second biggest risk for a Reclast related patients could be atypical femoral fractures, called atypical femoral fractures. So the long-term use of Reclast can increase the risk of atypical fractures. Usually these fractures that can occur in the femur, in the long bone of your hip bone, and the risk is, although small, it can happen, and we need to make sure that the patient is aware of it. New York Times about maybe 15 years ago, published an article. And after that, many studies have also said that if you are using this medication long term, consider a drug holiday, or at least risk analysis needs to be done with the patient. Now, if, as I mentioned earlier, renal impairment is another problem, if the patient has renal injury, Reclast is not indicated because it can cause further uh, risk of toxicity of the medicine because it's not going to be cleared. So through the kidney problem, so pre-existing kidney issues essentially exclude the use of Reclast in most of my patients. So one option would be to switch her to Prolia, or the other option would be to consider a drug holiday. And let's talk about those. What is a drug holiday? A drug holiday is where you have been given a medicine for 5 to 10 years, such as Reclast. You take 1 or 2 years break and then restart the medication. A drug holiday can help reduce the risk of long-term side effects such as osteonecrosis of the jawbone or atypical femoral fractures. If the patient bone mineral density is stable and they are at a low risk, taking a break from the Reclast may be an ideal option. Um, we, during that time period, carefully monitor for worsening of bone density. It usually does not happen because we ensure patients that they should continue doing exercise and bone healthy nutrition. During this holiday week, monitor for blood tests, vitamin D levels, parathyroid hormone levels, and also bone density scans so that we can assess and retreat the patients when needed. Now, this option that my patient was hesitant about was Prolia, because when I offered her, I told her, like, well, you've been on this medication for 10 years for Reclast, let me switch you to Prolia. And she's like, I don't know if I want to consider it. And I said, why? And she said, well, I am so used to a Reclast that I don't want to consider another medication. So let's make a case about Prolia. Another option for long-term treatment management for osteoporosis is uh, Prolia, which is denosumab. And benefits of Prolia is it's an effective medicine at increasing the bone mineral density and reducing the fracture risks. It is administered as an injection every 6 months under your skin. It's a small needle. You come in the clinic and we give you an injection. Our nurses give you. This may be more appealing for patients who prefer not to have yearly IV infusion. Now, risk of Prolia, there are some risk of Prolia which are sort of similar to Reclast, but there's some differences. The difference is that it can lead to low calcium levels. We talked about calcium in previous videos and another episode, but you need to make sure you are on a calcium-rich food so that you don't become calcium deprived. And increase. Number two, Prolia was initially discovered as a rheumatoid arthritis medicine. It has some effect on the immune system. So if there is a patient who is at a risk of infection, I like to discuss that with them and also not give the medicine if they are fighting an infection. And again, the small risk of osteonecrosis of the jawbone still exists with Prolia. So if you are uh, getting dental hygiene and you don't have comorbid conditions such as cancer or smoker or chronic kidney disease, complication rates are much lower. But make sure you know that you cannot stop Prolia cold turkey. It has to be gradually weaned off to another medication such as Reclast or oral bisphosphonate or Evenity to uh, kind of bind in all the benefits of the Prolia. So one warning for Prolia patients are do not stop it cold turkey, otherwise you will lose all the benefits. So what should this 74-year-old patient should do who has been on Reclast for about 10 years? The decision depends on number of factors, such as overall fracture risk, her bone density, how stable it has been, and personal preference. Whether she would continue Reclast, whether she would go on to Prolia, whether she would take a drug holiday is a shared decision between the patient and the doctor. So I think that we will have continued open discussion with the patient, and I've also considered uh, considered involving her primary care in that decision. So, um, It's always a combined decision. You should talk to your doctor and bring up your questions and concerns. That is the end of this topic. If you found this information helpful, please give this video a thumbs up, like it, share it, subscribe to my channel, and I will continue to produce uh, information regarding autoimmunity, obesity, and longevity approaches to life for you in the uh, on the regular basis. Until then, take care of yourself and see you in the next video.